Hi, everyone. Thanks for joining us. We're going to give folks just a couple seconds to get their computers connected and make sure that they don't miss all the important stuff that you're turning in to hear today. So we're going to just pause for this awkward moment of silence. All right. Well, I'd like to go ahead and get us started for today. Happy Friday, everyone. I am Kathleen Christ, and I'm the Executive Director of Houston Area Parkinson Society, and this is our Community Partners Presents program. This is an opportunity that comes up several times a year, webinar style, for people to learn more about treatment options, about disease information. And so this is a great opportunity to get to kind of further your knowledge and understanding of things so that you can have more informed conversations with your providers and take a more proactive approach to disease management. So today, we're actually not going to be talking about necessarily treatment strategies. This is a topic that we're getting lots of questions about that seems to be coming up more and more, and that is on atypical disorders. Many of you are familiar that Houston Area Parkinson Society serves individuals with Parkinson's and related disorders. And so today, Dr. Bill Nitzer is going to fill us in on what those related disorders are and give us more information. So, if you've done one of these webinars with us in the past, then you know that you can submit your questions throughout the course of the program. I will be paying attention to my cell phone because I know some of you like to text instead of putting your messages in chat. I mean, not chat, I'm sorry, in the Q&A. And by the way, if you have recently done a Zoom update, then you're going to find that the Q&A feature has kind of moved. So at the bottom of your screen, you'll see a round circle with three dots in the middle that says more underneath it. If you click on that, that will take you to the button where you can find the Q&A and submit your questions that way. So if we have questions at the end, we will get to your questions and make sure that we get those things answered. Obviously, Dr. Bill Nitzer will only be able to answer the stuff that's more general, not the personal medical information. So before I let him get started, I want to do a proper introduction. But Dr. Andrew Bill Nitzer is a movement disorder specialist, assistant professor of clinical neurology at Houston Methodist in the Stanley H. Appel Department of Neurology. He's a co-author of lots of professional articles, or author and co-author, I should say, of lots of professional articles. Many of you are probably familiar with him because he is a member of our medical advisory board and has been presenting for us at several at our symposium as well as our PD 101 event. And so he is probably a very familiar face to most of you. All right, with that, Dr. Bill Nitzer, I'm going to say thank you for joining us and for filling us in today on all of this information, and I will turn it over to you.
Great. Well, thanks, Kathleen, for the introduction. Thanks, everyone, for joining. Like Kathleen had said, this is a talk on atypical Parkinsonism. The ending is really particular when it comes to medical terminology, and we'll talk more about that. But these are conditions that can sometimes look like Parkinson's disease, but have different trajectories or different treatment strategies and different symptoms. And sometimes they can trick providers. Sometimes they can throw people off, and so we'll go through it and we'll kind of talk about how to interpret this, with your own diagnoses and go forward from there. So let me see, get this going. All right. So I talked about Parkinsonism. So what is Parkinsonism? Parkinsonism is the medical term that we give for any condition that causes a combination of the movement abnormalities that we see in Parkinson's disease. So that's either the typical rest tremor, slow movement, or what we refer to as bradykinesia, this unique muscle stiffness that we call rigidity or sometimes cogwheel rigidity, and then changes to walking, balance, gait, whether it's taking more steps when you're walking or not swinging your arms or feeling more off balance with walking. When you look at the makeup of all of the conditions that cause Parkinsonism, the vast majority, 85%, probably more, is caused by Parkinson's disease. And then a lesser extent is caused by these other groups of conditions that are called atypical Parkinsonisms. So, if anybody, I always tell the residents, if anybody's walking into my office and they have any of these symptoms, and they tell me that they think the patient has Parkinson's disease, they're probably right. If you were in Vegas, you'd put your money down on Parkinson's disease because the atypical Parkinsonisms are rare conditions. So, this is more maybe a review. I mean, what is Parkinson's disease? Parkinson's disease is a unique condition that can present with gradual onset of Parkinsonism. There's a few features of it that kind of tell the clinician or your provider, hey, we're dealing with Parkinson's disease and not something else. So typically, Parkinson's disease starts on one side of the body, either the right or the left, either the leg or the arm. And it's characterized by this slow, diminutive movement. That's one of the very key cardinal features. But more than 2/3 of the time, it's also accompanied by a rest tremor, stiffness, or rigidity. I put tremor on there twice. That's a mistake. It's not that important. I mean, it's still important, but anyway, stoop posture or imbalance. And then the one other key characteristic of Parkinson's disease is that if we give you the medicine for Parkinson's disease, levodopa, carbidopa, levodopa, Sinemet, or some, variation thereof, you tend to have a lot of good response to it, meaning the tremor gets better or the bradykinesia improves, the stiffness resolves, you walk faster. I mean, we almost I don't think they do it anymore. I mean, we don't do it in our clinic, but back in the 60s and 70s when they first had the medicine for this, they would just give the medicine in the clinic and make sure you got better. And then they would say, voila, that's the diagnosis because you're responding to the medicine. So that becomes important later on when we talk about these other conditions. Parkinson's disease can have other symptoms that are not necessarily related to movement. And so we as clinicians, we call these non-motor symptoms. It's not locomotion, but it's other things. So that can be dysfunction in anywhere in what we call the autonomic nervous system. This is your nervous system that's on autopilot, so digestion and regulating blood pressure. And so some of the symptoms that can come on for patients might be constipation, lightheadedness or dizziness with standing up, or what we call orthostatic hypotension, erectile dysfunction, or changes to bladder control where you have some bladder urgency. Um, I should mention, just because these symptoms are listed here doesn't mean everyone gets them. In fact, nobody gets all the symptoms that are listed on either slide. It's always a combination thereof, but these are things that we always will ask about. You can have some neuropsychiatric symptoms, either depressed mood or what we call anhedonia, lack of motivation, increased anxiety. With the medicines, you might have some impulse control side effects. This might be things like going on shopping sprees or gambling or things like that. Hallucinations or delirium or psychosis, which typically is related to the medicines as well. And then a proportion of patients might develop some cognitive changes or what we call Parkinson's disease dementia in later stages. Other symptoms that we'll ask about will be things like restless leg syndrome, REM behavior disorder, which is when um, you're sleeping at night and whatever you're doing in the dream, you're doing in the bed. So patients will be kicking and punching the air, or uh, you know, if they're playing soccer in their dream, they're playing soccer in the bed, and it ends up kicking the partner. You can have fatigue, which is very common, drooling or changes to kind of swallowing or salivation. Anosmia is a change in your sense of smell, or some patients will report some sensory changes as well. So all of these kind of fall into that Parkinson's disease category. Again, we talked Parkinson's as a kind of a common condition, and it's very common that patients present in any number of ways with any combination of these symptoms. Atypical Parkinsonisms, uh, we'll get into a little more now. We sometimes refer to these as Parkinson's plus syndromes, and that's because they have basically all the features of Parkinson's disease plus something else. And that something else kind of points us to a different diagnosis, and that tends to matter because we will approach prognosis and treatment and things differently in these patients. So oftentimes, if you have an atypical Parkinsonism, it comes on a little quicker and it tends to have some more severe either motor symptoms or non-motor symptoms than what would be expected in typical Parkinson's disease. We talked about how there will be some extra symptoms that we don't necessarily expect to see in Parkinson's disease. And generally, they progress on a faster timeline than Parkinson's disease. Michael J. Fox, I don't know the exact time, but he's had Parkinson's for almost 30 years now. Most atypical Parkinsonisms progress much faster and can lead to more disability on a quicker timeline. This is where giving them medicine, so typically, if you have an atypical Parkinsonism and we give you levodopa therapy, you tend not to see as much of a robust improvement. So sometimes if we're thinking someone has Parkinson's disease and we give them the medicine and they don't respond, it makes us kind of take a step back and see, did I get it right? Most times it's just a matter of the right dose or tolerance more than, having missed a different diagnosis, but it does come up. Uh, the ones that we'll talk about today, we'll go through each of these individually, but these would be the names you might have read or heard: multiple system atrophy, progressive supranuclear palsy, dementia with Lewy bodies, and corticobasal syndrome. And then there's a few others that kind of cross over with Parkinson's, and that would be normal pressure hydrocephalus and vascular Parkinsonism. Like I said, we'll talk about these. This is kind of a demonstration of where these things land from like a clinical standpoint. So, you have the big bubble of Parkinsonism, and then within that, signs and symptoms. Parkinson's disease takes up a huge chunk of it, but you can have patients who have dementia with Lewy bodies who have a lot of the same symptoms that Parkinson's disease patients have, but then they have other symptoms that are outside of that, like cognitive dysfunction or more autonomic dysfunction. You can have MSA patients, again, can look like Parkinson's disease, but they have severe balance problems. Progressive supranuclear palsy patients will have eye movement problems. Corticobasal syndrome patients will have what we call an alien limb phenomenon. So while a lot of it does look like Parkinson's, and I've been tricked, there are often some things that kind of point us in the other direction. I'm going to get heavy into the weeds here, but this is kind of more if you're interested. We know that Parkinson's disease develops because a bad protein is building up in the brain, and that protein is called alpha-synuclein. And that same protein also builds up in other atypical Parkinsonism. So patients who have multiple system atrophy or dementia with Lewy bodies also have alpha-synuclein proteins in the brain. And the reason these conditions end up presenting differently than Parkinson's disease is because the protein is actually going to different spots in the brain. So in the Parkinson's disease, the proteins are going to the basal ganglia, which is the area that controls movement. And multiple system atrophy, it's actually going to the brainstem, which controls a lot of what we call our autonomic functions. And then with dementia with Lewy bodies, the protein's actually going to what we call the cortex, or the outside of the brain. And that, goes more with like thinking and cognition and things like that. Uh, the other protein that can build up in atypical Parkinsonisms is one called tau. And tau is a common protein that builds up in the brain in Alzheimer's disease. But if it builds up in the brainstem and the body, then you get something like progressive supranuclear palsy, or again, if it builds up on one side of the brain that controls your limbs or movements, you get something called corticobasal syndrome. We don't know where these proteins start. We don't necessarily know why they build up or why they go to certain areas of the brain or not. There's a lot of research going into this. And there's a few hypotheses, but we don't really have time to kind of get into that. Just know that this is actually how we make the diagnosis is if we could after someone's passed away, if you were to do an autopsy or brain biopsy, you look and you see where these proteins are, and in the medical literature, that's how you actually make the most definitive diagnoses of these conditions. So let's talk about multiple system atrophy. So multiple system atrophy, the name kind of implies what it is, meaning that you have multiple systems in the body that are kind of wasting or becoming dysfunctional. So one of the systems is a motor system, and that's why you get similar findings of Parkinson's disease, and you might have bradykinesia, rigidity, tremor, and the balance issues. But you also more commonly might have swallowing problems in multiple system atrophy than you would with regular Parkinson's disease. The other thing that's pretty prominent with multiple system atrophy compared to Parkinson's disease is the autonomic nervous system changes are much more profound. So I always have to kind of, and I'd have to tell this to the residents too, because they'll see someone who, comes in with Parkinson's disease and they're having lightheaded and they're being lightheaded and dizzy when they stand up, or they're having the constipation or, other autonomic symptoms, and they say, "Oh, you have orthostatic hypotension, so you have MSA." So that's not true. And again, everything goes with a grain of salt, and there's degrees of this. Patients with Parkinson's disease have autonomic dysfunction, but it is much more profound in multiple system atrophy, and there's a lot of crossover that kind of makes this a difficult diagnosis. Um, the other symptom that can come on with multiple system atrophy is specific coordination problems, one that we call ataxia. Typically, this is like a wide base stance, or if you're reaching out and grabbing something, you'll reach past it, or you'll just have more incoordination of the limbs. And we kind of test this with the same, the analogy is if someone's had too much to drink, they're kind of wobbly all over the place. I mean, that's what ataxia looks like because alcohol affects the same area of the brain. The other symptoms that can come on in MSA that we do not see in Parkinson's disease are things um, like breathing problems, called sleep apnea, deep, heavy sighs, what we call an inspiratory stridor, where they'll take a breath and you can kind of hear each time they breathe in. And so that can be a sign of like the vocal cords having some dysfunction. You can develop other symptoms, what we call pseudobulbar affect, which is some inappropriate laughing and crying at times when it's, again, not appropriate. You can have similar symptoms like depression, anxiety, and panic attacks. And you can have some of the very similar symptoms that you see in Parkinson's disease, like the REM behavior disorder, again, because it's the same protein that can affect similar areas of the brain. Or you can have this tilting to one side with walking, what we call Pisa syndrome. So, doc, I have some of those things. So I have MSA. Very likely not. And again, this is what I tell all my trainees. I mean, the prevalence of MSA is super rare, 3 to 5 per 100,000 individuals. The prevalence of Parkinson's disease is 1 in 100. So it's oftentimes more likely, even with these symptoms, that you have idiopathic Parkinson's disease rather than MSA, and it just looks different than your colleague or other someone else's Parkinson's disease. MSA tends to come on in kind of a younger onset age compared to Parkinson's disease, although again, there's always the overlap, but the mean onset is around 55. And it tends to affect men a little more common than women. And here's the reason I don't like to jump on an MSA diagnosis unless I'm clear. It's because the survival of these patients and how they progress, they tend to have a mean survival of 6 to 10 years, and they're often wheelchair bound by year 5, if not sooner. And so you can imagine giving someone a diagnosis of this right off the bat, and they go read about these conditions, and if it's the wrong diagnosis, you're giving them a lot of stress and strife. So again, we don't really make this diagnosis until we're absolutely sure, or we're seeing things that kind of send us in that direction. How do we make the diagnosis? You see a movement disorder specialist. I'm not tooting my own horn. I do not think general neurologists see enough of these conditions to make the call one way or the other. I think a general neurologist can diagnose Parkinson's disease. I think they would have some trouble diagnosing MSA. And oftentimes I get referrals to my clinic saying someone has MSA, and it's like I said, they have, low blood pressure was standing up, or they're having some erectile dysfunction, and someone jumped on that and they said, "Oh, it's MSA, go see Dr. Belnitzer." But they really have Parkinson's disease, which is, whew. So we will often get an MRI in cases when we're looking for MSA. The MRI in Parkinson's disease is normal. So if you're saying, "Hey, I have been diagnosed with Parkinson's, nobody's ever gotten an MRI on me," that's because we expect it to be normal. But if we're suspecting something like MSA, we might look at the brainstem. This area up here is the brainstem. I think we just had Easter. My family never does this for Easter, and but I don't know how many of y'all are familiar with hot cross buns, but this is the hot cross bun sign in the brainstem. Let's see, it's not really showing up on the screen here. You can see my pointer, but it's not synced up. Anyway, so but you can see that in the brainstem, we see this pattern where the specific area of the brainstem is wasting away in a cross pattern. And so again, we call that the hot cross bun sign. And then the other thing that we can see is there's a coordination center on the back of the brain here. Let's see if I can get the mouse there, that we call the cerebellum. And that is shrinking in these patients. This is that, again, that center that is for balance and making fine movements. And you can see that compared to the image on the left side, that area of the brain is smaller. So those are some hints that would tell us that we're dealing with a patient with MSA rather than Parkinson's disease. How do we manage it? A lot of the management for a lot of these conditions is very similar to how we manage Parkinson's disease. In fact, there's not really any unique treatment options that we don't already try in Parkinson's. It's just that they're kind of less effective in these conditions. So we lean heavily on physical therapy, occupational therapy, and speech therapy. We will often try levodopa in these patients, and some of them do have like a partial response or improvement in some symptoms. And then we treat the other symptoms. There are treatment options for, let's say, like low blood pressure or the urinary symptoms or bowel symptoms. I mean, there are targeted medicines just for those symptoms. And then there's also targeted medicines for, the pseudobulbar affect, depression, treatments for sleep apnea, and, walking aids to avoid falls. So again, we kind of break down the condition into what symptoms are interfering with the quality of life, and then we tailor our treatment based on that. Currently, as with Parkinson's, for all of the atypical Parkinsonisms, there's not what we call a cure or disease modifying therapy, but I'll touch on there's possibly some clinical trials that might show some benefit, and we'll have to see. Uh, so that's MSA. Let's move on to dementia with Lewy bodies. I think a lot of folks will ask me about this one very commonly in the office. And similar to MSA, there's a lot of crossover with Parkinson's disease. So, if you go on the dementia with Lewy body website, you'll start reading some of the symptoms and you'll say, maybe I have that. Why hasn't Dr. Belnitzer mentioned this as a possibility? But there's some very strict criteria for this as well. And again, the criteria matters because it influences the prognosis and the treatment. And so that's why we want to make sure we're keeping everything as accurate as we can. So dementia with Lewy bodies is primarily a dementia more than a movement problem. And so that means you're having early hallucinations or delusions or changes to your attention or arousal. And that tends to happen within 1 year of having any of the other Parkinson's symptoms. So, DLB patients tend to have, if they come in with a tremor and shuffling gait, I mean, they're having cognitive issues, 6 to 12 months later, or even having cognitive issues before that. So it's true that with Parkinson's, a proportion of patients might develop cognitive changes over time, but we often think about that, on a 10, 15-year time scale or something like that. So, that case, that's not dementia with Lewy bodies. That's a different diagnosis, Parkinson's disease dementia, and, it has different implications. Dementia with Lewy body patients can have mild Parkinsonism. They can also have that REM behavior disorder, and they can have autonomic dysfunction like constipation or orthostatic hypotension, which is the low blood pressure. And they can have a lot of anxiety and depression and psychiatric symptoms that kind of go along with it. They can be a little trickier to treat because if you give them levodopa, they might be more sensitive to some of the side effects of levodopa, and they might have some hallucinations really early on, which is a rare side effect of the levodopa, but it's more common in dementia with Lewy body. But this is actually what Robin Williams had. Um, it's the second most common type of degenerative dementia, and it accounts for 4.2% of all dementia diagnoses. Again, look at the number here. The incidence is about 3.5 per 100,000 persons. So again, compared to Parkinson's disease, which is 1 in 100, the prevalence is still very low, even though it's the second most common type of dementia. Typically, we think of a prognosis. Uh, it can be lethal, within 5 to 8 years from diagnosis, but it can also have an extended range anywhere from 2 to 20 years, depending on how quickly it moves. The typical age of onset is in the 70s. And I guess I had already mentioned this on the previous slide, but this is not Parkinson's disease, dementia, and vice versa. And again, it has to come down to these numbers and the prognoses and how we approach these patients. Um, how do we diagnose dementia with Lewy bodies? I mean, it's a clinical diagnosis, meaning we have to make the diagnosis in the office and we ask all the questions and we find which kind of bucket you fall into. But again, the key diagnosis on this one feature is that the dementia happens either within a year, either before or after that you develop any of the Parkinsonism. So, if it's happening 5 years after the fact, that's not dementia with Lewy bodies. We'll often use our colleagues, our neuropsychologists, to do some dementia testing, and they can actually see if the pattern of dementia looks like a specific pattern that we see in dementia with Lewy bodies, or if it looks like Alzheimer's or something else. The MRI of the brain can show some shrinking or atrophy in the front of the brain and then on the sides of the brain, what we call the parietal temporal region. And then this test is a PET scan, which measures metabolic activity in the brain. And we see a very typical pattern in dementia with Lewy body where the front of the brain is fine, but in the back of the brain, what we call this is where we control our vision. So we call it the visual cortex. You can see like if red is hot, meaning there's a lot of activity, there's not a lot of activity in the back of the brain. And this is where that alpha synuclein builds up. And since it's the visual part of the brain, it affects, you can start to see things, and this is where hallucinations come from. And so that's why these patients will often have hallucinations as part of their symptoms. So hallucinations, they can be worse with levodopa therapy, and we'll try to manage it with quetiapine, pimavanserin, or a medicine called clozapine. Y'all might be familiar with some of those because we use it for some of the hallucinations that might come on with levodopa. So we use the same ones here. There are other medicines, what are called antipsychotics, that if you were a patient diagnosed with schizophrenia and having hallucinations, they might use those. But when you use those in Parkinson's patients or dementia with Lewy body patients, it blocks all the dopamine, and then the Parkinson's gets worse, and you can have a lot of side effects with those. So, and specifically with dementia with Lewy bodies, because of the hallucinations early on, patients will get prescribed these, and then they kind of lock up. And so that's another hint that we're dealing with dementia with Lewy body rather than something else. Like the other therapies, we do PT and OT and speech therapy for these patients as well. We'll sometimes try some of these medicines for cognition. Y'all may be familiar with some of these, rivastigmine, donepezil, memantine. They are also used in Parkinson's disease and Alzheimer's disease. They're supposed to be kind of memory boosters. We'll treat depression and anxiety again with typical antidepressants. And then again, there's treatment options for the REM behavior disorder and the orthostatic hypotension. So again, no cure, but we will use what tools we have at our disposal to minimize any of the symptoms that you're having that are kind of interfering with quality of life. All right. So this is so that kind of accounts for the conditions that we call synucleinopathies or alpha synucleinopathies. So the Parkinson's disease, MSA, dementia with Lewy bodies. Again, there's a lot of crossover because of that same protein. It can cause different similar symptoms in different conditions. So it can be a little tricky to tease it out, and that's what again why a specialist in these conditions is important. Um, to kind of pick up on the nuances. So let's talk about some of these other conditions. I'm not going to talk about Alzheimer's, but we will talk about progressive supranuclear palsy. So this is a condition that can also mimic Parkinson's disease, um, but these patients will typically come in with early falls. So balance, fall problems are really common, often again within the first year of showing any symptoms. They often have kind of wider based stance when they're walking. And they also have another very particular feature, which is an inability to either look up or down. So we call it a vertical gaze palsy, but it may show up, I put food on the plate, but he's not finishing the food or can't tie a tie or buttoning buttons because the eyes are not able to look down or they're not able to look up. And so we will check that in the clinical exam room. In more severe cases, they might not be able to open their eyelids at all, what we call an eyelid opening apraxia. That's typically more of a delayed sign. And these pictures are what we call the Procerus sign, which is a little bit kind of like a frown or a scowl of the front of the brow, and we call it the Procerus sign because that's your Procerus muscle. And it's kind of like that activation of the Procerus muscle is a typical feature that comes on with progressive supranuclear palsy. Um, these patients will have Parkinsonism, but they typically do not have the tremor that we see with the other conditions. And they could have that typical, what we call freezing of gait, where feet get kind of stuck to the ground when you're walking. They also will have some slow thinking. They might have be slower to respond, and they might actually, in more advanced cases, you can lose your ability to actually speak, but it doesn't mean you're not understanding things. It's a very specific type of speech loss that we call expressive aphasia. It just means that you're having trouble getting the words out, but these patients are able to interpret and respond and nod appropriately to everything that's said. They just can't make the words. It's more common that these patients have that pseudobulbar affect, again, which is an inappropriate emotional response to the situation. And I guess I mentioned that. Yeah, the aphasia that comes on with it. So you might hear this being called Steele-Richardson syndrome, which is the two neurologists who first diagnosed the condition. And then there's different, we call them subtypes, which is, you can have progressive supranuclear palsy that looks a lot like Parkinson's disease. So we call that PSP Parkinsonism, or they're going to have more cognitive problems and speech problems. And so that's PSP frontal temporal dementia, or they have more balance problems. And so that's PSP cerebellar. It's a little bit of semantics because the distinguishing features don't necessarily change too much the prognosis. Again, it's a pretty low prevalence, 5 in 100,000 persons. Average age of onset is 63, and it affects men and women equally. And there is also a reduced survival time in this patient group too, about 7 years from symptom onset. How do we diagnose PSP? Again, we do a lot of things in the exam room to see if you are meeting typical clinical criteria. The other thing is we could get an MRI and this again, this is the top of the brainstem. This is what a normal brainstem looks like. We call this the midbrain. And then this is a midbrain that is shrinking. And so it looks like a morning glory flower. I'm not much of a gardener, but I've been told this is what a morning glory is. And so you can see that there's this same pattern at the top of the brainstem. Or the other thing that you can see is the top of the brainstem here is shrinking and it almost looks like a hummingbird. And so we'll call that the hummingbird sign. And this is where the gaze center in the brain is, and that accounts for why you have trouble looking up and down because that area of the brain is shrinking. This is a reference for those who are interested of what a normal brainstem looks like. So you can see that this top area that holds the gaze center and again coordinates some balance is shrinking. And again, you get kind of the hummingbird beak there. So a lot of crossover with the other conditions. Again, PT, OT, and SLP are mainstays of treatment. We will try levodopa in these patients, and they will sometimes have some partial benefit. Walking aids are key, especially with PSP. The main thing is falls, fall prevention, balance. That's the main thing that we're focusing on with PSP. And then medications for cognitive changes and pseudobulbar affect. Um, the other condition that I would say is probably the rarest of them all would be cortical basal syndrome. But this is the one that's tripped me up a couple of times. So this is, I mean, they all have it at one point, but this one is patients who develop Parkinsonism. It's typically on one side of the body. And the Parkinsonism comes on because they're actually having trouble controlling one of their limbs. And so you'll ask them, show me how you brush your teeth, and they can't do it. Or show me how you comb your hair. And they just kind of look at their hand like, I'm telling it to do something, but it's just not doing it. And other times the hand may seem like it's kind of wandering off on its own, what we call an alien limb phenomenon. It might grasp at things without the patient being aware. And if you were to like hand them a key and tell them to close their eyes and, what are you holding in your hand? They wouldn't be able to tell you. They can't kind of like interpret stuff. So it's an alien limb. It's a limb that's there, but it's kind of, you don't have control over it. You could also get some jerking symptoms with this, what we call myoclonus, which is like a brief jerk, and the limb itself can get really tight, and the muscles can get tight, and we call that spasticity or dystonia, and that can become painful as well. This condition can also present with cognitive changes and also trouble kind of interpreting where things are in space. One of the best examples when I was in training is we had a patient with this. We watched them walk up the stairs and they went to take a step and they took a huge stride to try to get on a step that was right in front of them because they just had trouble interpreting that distance. Sometimes this can be accompanied with some personality changes. And like all of these conditions, it can lead to some mood changes like depression, anxiety, or behavioral changes as well. So again, it's got a similar prevalence to the other, about 5 to 7 per 100,000 persons, mean age of onset in the 60s and 70s, and also a reduced survival time, 7 years from symptom onset, has no predilection for men or women. And this one's tricky because the MRI is subtle, but we will, so we'll try to make the diagnosis based on some of those things that I talked about. But we'll also, on the MRI, sometimes you can see, where's the mouse? This is the area of the brain that is controlling the hand. And on the other side, there's the same area of the brain that controls the other hand. And this area of the brain is shrinking. So sometimes you'll see that we call this asymmetric atrophy of the motor strip on the MRI. But again, it's more subtle, and you need to have the full clinical picture to really determine if that's what's going on. So for treatment for this, it's almost copy and paste from everything else. I mean, we'll try PTOT, speech therapy. Some of these patients have some benefits from levodopa, although, like I said, with all the atypical Parkinsonisms, it's not really typically that robust. Um, these patients will sometimes get Botox injections for that muscle stiffness or muscle relaxers like baclofen. If they are having any of those jerks, what we call myoclonus, there's treatments for that, walkers or ambulatory aids, and then again, monitoring for any cognitive symptoms. So those are the other conditions that we typically think are what of the atypical Parkinsonisms. I'm going to go into a few more that are what we would consider mimics. And so the next one is vascular Parkinsonism. And this is Parkinsonism that shows up because of small strokes or injuries to the blood vessels that are building up in the brain over time. And essentially, the small strokes are happening on such a small scale that when they happen, the patient doesn't really know that it's happening. But if it happens 10 or 12 times or 30 times, it starts to build up and they start to notice that they're having some problems. And so we often think there's a bit of more of like a stepwise progression with this. Like patients will do fine for a few months and then they feel like they're falling off, do fine for a few months and then they feel like they have another falling off. And they'll often report that in addition to the Parkinsonism, they have some processing issues too, because I'll show you on the image. I mean, all the connections with the brain are getting interrupted by these small strokes. Typically, this affects more of the legs than the arms. And that's just because of where the small strokes are happening in the brain. And these patients tend not to have a good response to levodopa, unfortunately. So for them, the mainstay of treatment, again, is more PTOT and speech therapy, but to also treat any of the risk factors that put them at risk for further strokes. Because at best, in these patients, we could at least try to stop things from getting worse by managing stroke risk factors. So this is like an example. Again, this would be uh, a normal brain. And then this would be one where, again, each one of these small dots is a small stroke. It could be, could have happened yesterday, it could have happened 20 years ago. It leaves a scar on the brain that's like a white scar. And you can imagine if you get enough of these, then your brain is no longer functioning at 100%. And you're trying to send a signal from this side of the brain to this side of the brain, but there are these interruptions in between. And so that's the same thing. You're trying to send a signal from the brain to the feet to say, hey, let's take a step, but it's not getting through. So it's really tough. I mean, there's not a way you can kind of go in and repair that. So the best thing to do with the PT is to work on new strategies for mobility, and again to keep things from getting worse by working with the doctor. Um, the other symptom that comes or condition that comes up that is a little trickier than the textbook would have you believe is one called normal pressure hydrocephalus. But this is a condition where everyone has the brain is floating around in fluid that we call cerebral spinal fluid. And you have these pockets in the brain that hold the fluid. And if the pockets are filling up too much, it starts pushing on the brain, and we call that hydrocephalus. And so normal pressure hydrocephalus means that there's nothing that's blocking the fluid from getting out. It just means that the pockets themselves are expanding. And this has a this what we call a characteristic triad, a clinical triad of patients will present with personality changes or cognitive changes. They'll have a really particular pattern of walking that we call a magnetic gait, where it's almost like their feet are magnetized to the ground and they really just they're not able to pick up a foot to even make a movement. It looks a little different than freezing. It's not quite freezing. And then they'll commonly have like early urinary incontinence as well. An MRI or a CT tends to show a picture like this. So if you look back here, these are the kind of these are the normal sides of the fluid pockets. Um, and then if you look over here, you can see that they've gotten a lot bigger. And so for cases like this, we'll often send to we have a neuro or an NPH, normal pressure hydrocephalus specialist at Methodist, but most groups will have some kind of protocol where they actually will either put you in the hospital and drain off some of the fluid using a spinal tap or a lumbar puncture, and they'll actually see if some of these symptoms improve. And if those symptoms improve, that suggests that you could benefit from having a procedure called a shunt that helps with the walking and the cognitive changes and things like that. There is some, uh, the trial is really important before you get the shunt because the shunt itself can also cause some complications. And so it's best to, again, do this with a specialty center. The other tricky thing about this condition is some folks who have idiopathic Parkinson's disease can have large ventricles in the brain, or PSP patients can have large ventricles in the brain. What these fluid sacs, those are the ventricles. And it's like borderline. It's like, well, do you want to put a shunt in someone who has Parkinson's disease if it has risk of, bleeding in the brain and things like that? So again, it's always best to go to a specialist who has experience with all of these conditions so they can really make sure that you're dealing with the right condition. So just a few general comments. There is a significant crossover of symptoms in atypical Parkinsonisms. If you all did not kind of gather that from the talk. In fact, it is difficult even for very experienced clinicians and specialists to sometimes make the right diagnosis. There's not one definitive test. Sometimes early on in these symptoms, we'll get the MRI and it doesn't have the characteristic finding, and that finding doesn't necessarily show up until the patient has had symptoms for 4 or 5 years. So your clinician is basically making their best guess. There's special criteria that is within the medical literature that kind of puts patients in different categories, and your physicians generally ascribe by this when they're making the diagnosis. The strategies and medications that are designed for Parkinson's disease are typically the same treatments that we will try in atypical Parkinsonism. Outside of a few like rare cases with some, extra symptoms, we often try the same treatments in Parkinson's disease that we do in atypical Parkinsonism. So there are some times where I'll tell a patient, I don't know, this doesn't necessarily look like Parkinson's disease. You might have an atypical Parkinsonism, but I don't actually know which one it is because there's not enough symptoms pointing me one way or the other. But to put it from a practical standpoint, we're going to take the symptoms one at a time, and we're going to try the same treatments regardless. And so, the diagnosis is, it's not that it's not important, but it's more that it's not going to affect the management there that day in the office because we're still going to be trying things based on the symptoms. So sometimes we do not actually get a diagnosis, and we just do our best kind of treating the symptoms that we have in front of us. As with Parkinson's disease, with atypical Parkinsonisms, nobody ever gets all of the symptoms that are listed as criteria, and the treatment is often individualized to the patient. All of the treatment options at this moment in time are there to improve quality of life and mitigate symptoms. But at this moment in time, there's not what we call a disease modifying therapy, anything that's going to necessarily slow down the progression of these conditions. We kind of extrapolate from Parkinson's disease. We encourage exercise and activity and the PT and all that because we do generally think that exercise, movement, physical activity does slow neurodegenerative conditions across the board. So we do kind of keep the same recommendations for our atypical Parkinsonism patients that we do for Parkinson's disease. There are a few early stage clinical trials for some of these conditions. If you've been diagnosed with PSP or MSA, there are a few trials that are looking at some novel therapies that might slow things down. I think here in Houston, the only organization that's doing them at the moment, I think, is Baylor. It's a good thing if you go to the research seminar in May, you might hear more about some of these things. For the vast majority of the patients on this call, I know this is the Parkinson Society, and it's, most patients have been diagnosed with Parkinson's disease. And I think the point of the talk and the takeaway is there's a lot of things that overlap, again, with these atypical Parkinsonisms. And if you're not careful, you can kind of get, don't want you to worry you guys itself that some of these things that we see in MSA and dementia with Lewy body and PSP and cortical basal syndrome, we also see in Parkinson's disease. So these are really tough conditions to figure out, and it's best that you kind of explain everything with your physician and make sure that you guys are coming to what the most appropriate diagnosis is. But far and away, Parkinsonism, walking into the clinic is Parkinson's disease more often than not. So I think that's just my big takeaway whenever I talk about these conditions. If you have been diagnosed with one of these conditions, I was, asking Kathleen before the call. I mean, there are resources that HAPS has available to you, and I'm sure she can touch on that a little more. For anyone who does carry one of these diagnoses, if you haven't been referred to any of these websites, these are websites that are resources for research or keeping up on new trials or supports or anything of the like. So I'll leave this with you, and I asked Kathleen that she can share these slides with whoever wants them. So with that, I appreciate everyone's time, and I'm very happy to take any questions that have come up.
All right. Thank you, Dr. Bill Nitzer. I know that this is sometimes overwhelming to get this information and to be thinking, hearing about all the crossover and thinking, oh, is something different happening that I should know about? But really, that there is a lot of crossover. These are very rare, and you really have to have a good working relationship and communication with your physician if something is not adding up quite right. So, okay, we do have some questions that came in. One, somebody asked, would drug-induced Parkinson's be considered an atypical Parkinson's disorder?
That's a great question. It is not typically drug-induced Parkinson or typically an atypical Parkinsonism points to what we call a neurodegenerative disorder, meaning it's a bad protein, it's building up, then it's causing symptoms to get worse over time. Drug-induced Parkinsonism is a Parkinsonism. You got me. I didn't put it on the slide. But the one of the hopeful things about drug-induced Parkinsonism is if you can remove the offending drug, drug-induced Parkinsonism happens when you're taking a drug that's blocking dopamine in the brain. So if you were to take that drug away, hopefully the Parkinsonism improves. There are occasions where you may have early Parkinson's disease and have been on one of those drugs, and it just made the Parkinson's disease show up quicker because it's blocking already low dopamine levels. But again, taking away the drug should help to improve some of those symptoms.
Okay, thank you. So there were lots of questions about the diagnostic process here. So I'm going to kind of ask, these will be kind of a series of questions related to that. If someone has had a DAT scan and has been told, you have Parkinson's, or that's what they're taking away from that, can you explain how the DAT scan can or cannot differentiate between some of these other disorders and whether or not some of these disorders are going to show up on a DAT scan?
That is a great question. I should actually put a slide on that next time. So a DAT scan, what it essentially measures, and what I tell patients is it measures your dopamine levels in the brain. So they give you a special tag or dye, and it latches onto these dopamine receptor or transporters, and we use that as a marker to measure if your dopamine levels are low or normal. So in Parkinson's disease, it is expected that the DAT scan is going to show low dopamine levels. For a lot of these atypical Parkinsonisms, you can have a DAT scan that shows the same thing as Parkinson's disease, meaning a positive DAT scan will show up in multiple system atrophy or dementia with Lewy bodies. For PSP or cortical basal syndrome, the DAT scan tends to be, it could be like 50-50. Like there's research that has shown that it could be positive or negative. And then with the vascular Parkinsonism and NPH, same thing. So it's not really a good test for an atypical Parkinsonism versus Parkinson's disease. It's a great test for drug-induced Parkinsonism, which we just briefly talked about. That's kind of the main test to determine if it's drug-induced Parkinsonism versus Parkinson's disease, or if you've had a really bad tremor and you want to make sure it's Parkinson's versus a condition called essential tremor. But yeah, it's a great question, but it really doesn't, it's really not all that helpful for discerning these conditions.
Okay, kind of along the same lines is skin biopsies.
Mhm.
There's now this new tool that's available. And do these atypical disorders show up in any of the skin biopsy results that people might go through?
Yes. So I'm going to go to this slide. So any of the conditions that have alpha-synuclein are going to show up positive on the skin biopsy. So if you have a positive skin biopsy, you don't have progressive supranuclear palsy or cortical basal syndrome, but you could have any one of these: Parkinson's disease, multiple system atrophy, or dementia with Lewy bodies. The skin biopsy is measuring alpha-synuclein in the skin. So that can be positive across all three of these. There is maybe some suggestion that the the skin biopsy can pick up distinguishing features between Parkinson's disease and MSA, but they haven't kind of rolled that out as a like a clinical tool yet. So for right now, all a positive skin biopsy tells you is if you have what we call an alpha-synucleinopathy, which includes Parkinson's disease.
And is there a related or a similar test that would pick up like a tauopathy that, that might indicate, I mean, in the kind of in the Alzheimer's spectrum, which is not the spectrum that I work in, but um,
Right.
yeah, I don't, is there,
Yeah. Yeah, nothing that is convenient. Most of the testing for tau, as we know it, they're either sampling it from the cerebral spinal fluid, like through a spinal tap. I think that's the only thing I'm familiar with at this moment. They might have an imaging test later on for that, but for right now, no.
okay. And there's lots of discussion about MRIs. And so a couple of questions related to that. Should someone request, get an MRI to see what's going on? And then the other question was related to MRI is why is it that you can see or can, I guess the question is really, why is it that you can see atypical disorders on MRI, but Parkinson's does not show up through MRI?
So, great question. So as I mentioned, and if any of my patients are on the call and they're wondering why hasn't Dr. Billnitzer MRI'd me, it's because I'm pretty confident you have Parkinson's disease. But the so the reason that some of these symptoms show, so I guess twofold. I mean, the MRI is actually not part of the diagnostic criteria for Parkinson's disease, and most clinicians expect it to be normal. And if you have characteristic Parkinson's symptoms, you don't have any atypical features, which, a movement disorder neurologist is looking for or asking about, even if they're not telling you. Um, and if you respond well to levodopa, that is good enough for 99% of patients to say this is Parkinson's disease that we're dealing with. Um, the reason Parkinson's doesn't show up on MRI is just that the changes happen on like a microscopic level, and it's a very, very particular area of the brain that's affected. And if you so it's the substantia nigra, which if you went in there and measured it with special volumetric tools and stuff, there's been data that shows that okay, maybe that area is shrinking, but not enough to the radiologist eye to really make the determination. The reason these things show up on MRI for a typical Parkinsonism is probably because these conditions progress faster. And so you see an accelerated shrinking of these neurons and they're kind of more damaging. So they leave more scars on the brain. So that would be my general interpretation. But like I said, even patients who are in the early stages of these conditions, sometimes their MRIs are normal, and because the change is still on a microscopic scale, and we don't see the change until we repeat it 3 or 4 years down the line.
Right. So later on, it might show up then.
Right.
Okay. You mentioned that general neurologists often don't have enough experience with these disorders to really pick them up from a diagnostic standpoint. So if you went to a movement disorder specialist for the diagnostic piece of this, would it be also important to remain with the movement disorder specialist to treat this, or do you feel that that this is something that can be managed by general neurology?
I think if you've been diagnosed with an atypical Parkinsonism, there are benefits to being in a movement disorder clinic, mainly the familiarity with the symptoms, because I can count on one hand the number of MSA patients I have or PSP patients. So if you think about a neurologist who's taking all comers, they are not going to be having that much experience. Like they will see maybe one or two of these in a career or something like that. Um, but most movement disorder centers are at the forefront of treatments. They're more familiar with, novel therapies for Parkinson's, and because of the crossover, they're familiar with, um, if we could use these novel treatments in these conditions or clinical trials, like I mentioned, the clinical trials will be coming to movement disorder practices, not a general neurology practice, and that comes down to recruitment. Any company who's going to be coming out with a new drug wants to find the folks who are going to have the highest concentration of these patients because they are really rare. So they're going to be looking at those centers as well.
And what would be the benefit of getting a diagnosis switched or kind of change in diagnosis? What's the benefit to learning that?
So I think part of it helps with planning ahead and knowing what to expect. Part of it puts you kind of in the mindset of uh, am I going to be like as clinical trials are rolling out for this, that's going to become more important as well in terms of diagnoses. But I think about it more in terms of prognostication, and then I think it helps the provider manage both expectations, target therapy towards, things that they might anticipate, right? I'm going to be more aggressive with someone who I suspect has PSP. We're really going to hit balance and PT and walking aids hard, and we're going to talk about, cognitive interventions early on, whereas, with Parkinson's patient, we have time to see if any symptoms are even going to develop. So it kind of helps you to anticipate and put you up for I always say we're maximizing the quality of life and approaching or anticipating symptoms that might come up. For MSA patients, I actually like to get them in with a sleep medicine doctor early because if they are going to have sleep problems or respiratory issues, they can benefit from having a CPAP device and things like that. So
Yeah, so the resource aspect is important and knowing what resources are appropriate or just what resources are helpful because if you do have an atypical Parkinsonism, then just learning about Parkinson's isn't going to feel like a very good fit for you. Like, this stuff doesn't apply. So it can be helpful to get connected to those resources that are more helpful. Okay. We're down to like just a few questions left. One is it possible not to have a robust response to levodopa and still just have Parkinson's?
yes. In fact, that's probably the most common thing. If you're not having that robust response, but you're hitting, all the other criteria, it's probably just more common that that's how the Parkinson's is manifesting. So I know I kind of hinted in a million different ways, but there is a lot of crossover. But far and away, the more common thing with any of these is a Parkinson's disease that's just not acting like the others rather than a brand new condition, if that makes sense.
Right. And what about what about things that might help clean up the bad protein in the brain? Someone wanted to know whether or not something like intermittent fasting, where you're not eating for 16 hours, if that might have any influence on that, um, or if exercise even has the same neuroprotective benefits with atypical disorders that they seem to with Parkinson's.
We extrapolate a lot from Parkinson's disease because the rarity of these conditions. It is actually tough to get a lot of data on them. So a lot of what we have, we do extrapolate from Parkinson's, but in terms of lifestyle, I would tell you the same things that I would tell the Parkinson's patients is that, Mediterranean diet and exercise, vigorous exercise, slow down inflammation and can help to, protect neurons. There's no way from a lifestyle standpoint that's been proven that I'm aware of that will, kind of clean up those bad proteins. There are clinical trials that have been, and they just finished one with MSA, and they're kind of crunching the numbers that are like the new Alzheimer's drug, where they gave an what we call an antibody that is targeted towards the alpha-synuclein and goes in and eats it up. But those are just that, a clinical trial, and we're still waiting to hear the results of that. So they're looking at medicines that target that as part of the research, but we just don't have the answer yet.
Okay. I'm looking for ways to get donuts on that Mediterranean diet. So, more research to come on that,
Wheat
maybe.
croissant or
Yeah. I don't think any of it counts. Is DBS, an effective tool or even a reasonable tool to be considered, treatment option to be considered with the atypical disorders?
Great question. It's actually a contraindication to DBS is if you have one of these atypical disorders. In early studies, they actually saw that patients who had atypical Parkinsonisms don't do well with DBS. And so it does not help with these conditions, unfortunately. It kind of goes back, the things that get better with DBS are the things that get better with levodopa. So, if these conditions aren't responding well to levodopa, you can kind of predict that they're not going to have a good response to DBS, unfortunately. Great
Okay.
question.
And that's also kind of part of the reason that DBS is not used right away,
Correct.
is because what we're doing over the course of those first few years is really locking in on this is, we're pretty solid in our confidence that this is Parkinson's and not an atypical disorder.
Mhm.
Yeah. Okay. Well, we have come to the end of our questions here. A couple of things that I will mention. Dr. Billnitzer alluded to our the research fair that's coming up May 30th, and you can reach out to the HAPS office. I cannot remember off the top of my head. I believe it's on the website, but I can't remember if it is. Certainly on our calendar, it is, but you can also follow us on social media and in our newsletter, and there's lots of information about that there. That'll be an opportunity for you all to come and hear from our local institutions here, Houston Methodist, Baylor, UT, the VA, and others, to learn more about the types of research that are going on that you might be interested in, either participating or learning more about. And it gives you the opportunity as well to talk to some of those investigators and other people involved in the trials and studies going on. So if you want more information, you can reach out. Dr. Bill Nitzer also mentioned the fact that his presentation is available if you would like it. And so I'm happy to email that to anyone that is interested, rather than just emailing it to everyone. If you'd like it, you can email me at crist@haps.org. So it's CRIST at haps.org, or you can go info@haps.org, and we can get it to you that way. And finally, well, maybe not quite finally, but the other thing that Dr. Billnitzer mentioned is that HAPS does have services and resources for folks who do have atypical disorders. So if you've been diagnosed with a atypical Parkinsonism, then certainly we have exercise classes that are still appropriate for your participation. We have a specific atypical Parkinson's support group that meets monthly, as well as case management, social work, and all the other programs and services that you can take part in here at HAPS. So what I will say finally is thank you, Dr. Billnitzer, for your time. We really appreciate it. I think that this is good information for people to get. I've got several texts and a couple of mentions in the Q&A thanking you for the information, saying that this was very informative, that they learned a lot, that it was easy to understand, and they appreciate your time, as of course we always do here. So with that, we will let Dr. Billnitzer, as well as all the rest of you, get back to your Friday afternoon, and thank you for joining us.
Thanks for having me. Thanks,
All right.
everyone.
Bye-bye.